Yes, so welcome to our fireside chat tonight from Harm to Hope. And we have with us tonight Casey Berna. Right, I'm just gonna allow Casey to introduce herself.
Hi there. I'm so grateful to be here and just so honored. Should I start the presentation? No,
No,
not yet.
just
Okay.
introduce yourself and then I'll ask some questions and then we'll get started.
Okay, perfect. I'm so grateful and honored to be with everyone tonight. I greatly admire the work that She is Lotus does and the advocacy. I really enjoyed the film they just put out and just am huge fans of this organization. So to be speaking this evening is a true honor. I am a licensed clinical social worker, and I've been working in the endometriosis, infertility, pregnancy loss, chronic illness communities for the past 15 years as a mental health provider and also as a patient advocate.
Thank you so much, Casey. Okay, so just before we get started, I'm just going to ask two questions and then I'll be placing them in the chat so that we can give persons something to think about during your presentation. And then, yeah. So we wanted to ask the audience what is one thing you wish healthcare providers better understood about living with endometriosis? And if you're comfortable, you can share that in the chat. And what has helped you most in coping with endometriosis, whether it be support groups, family, mental health care, advocacy, or anything else? So, any coping strategies that you have, we would like you to share in the chat. Okay, and now I'm gonna go back over to you, Casey, and you can take it from here.
Yeah,
Excellent. Those are two really good questions.
I will highlight you. Perfect. And thank you so much again, Casey, for joining us. We really, really appreciate it. As a review, guys, Casey's going to be going over her new book. We're going to be going over ACOG's new guidelines and the impacts of said guidelines globally. Take it away. Thank you.
Excellent. Okay, I'm going to try to share my screen without much fuss. Let's see. Okay. All right, how is this looking?
Good.
Okay, excellent. Okay, so I'm so grateful again to be here, and I'm going to talk about my work as a social worker. I'm going to talk a little bit about my book, and I'm going to focus a lot on the new ACOG practice bulletin that just came out. It's been a topic of conversation in the community. And I'm just grateful to be here with you all tonight to talk about it. And I'll be talking a little bit about my book, which actually talks about a lot of this stuff as well. Okay, just bear with me. Um, I don't have any financial disclosures or financial ties or alliances to disclose. I'm going to try not to have my thumb on the camera as well. Okay, let's see. Okay, I did want to do a personal disclosure though. I feel very honored to be here talking about this, but I really want to stress that any changes, any positive changes to the ACOG practice guidelines that just came out was a really like a collaborative community effort of dedicated patient advocates, which I am grateful to be one of them. And I'll talk about everyone today. And I'm kind of going to go over really the changes from when I started, which started in about 2017. Um, and so even though I'm speaking today, there are others involved. Heather, who I know is on the call here tonight. She also helped, was instrumental in the fight for change. Jenna Reish from Endometriosis Coalition, Shannon Cohen from Project Endo Global, and Lauren Cornegay from Endo Black. So I'm talking, so I don't want to speak for them. Thoughts and opinions are on my own, but I do want to recognize them. I also like to say that I'm not a medical provider, I'm a social worker. Even though, we talk about how the medical care has a profound impact on us. So I think it's okay to talk about. Again, the work would not be possible without other advocates, and the fight for change came even before I was menstruating. There's been long time efforts to try to change the ACOG standards of care, and I want to plug Heather's chapter that she wrote in the book, Women's Health and Corporate Marketing, Our Bodies, Their Business. And her chapter is brilliant and goes over a lot of the history. So I definitely recommend that if you want a more comprehensive view of the situation. And so again, today I'm going to talk about my role in the community as a social worker and my path to advocacy work. I'm going to talk a lot about the old ACOG practice bulletin and a lot of the harms that were included in the bulletin and the impact that they had on patients, the profound impact and harm that they had. I'm going to talk about the recent initiatives to change. I'm going to break down the new bulletin. I'm going to address that there are a lot of critiques to the new bulletin. And then we're going to talk about standards of care around the globe just a little bit. We're going to touch on that and sort of like, where do we go from here? And there's so much change that has to happen. And, this new diagnostic bulletin is just sort of like a blip, an important blip, but really, how do we implement these changes and then continue fighting for even like more changes and access to care. So a little bit about myself. I wear a few hats in the endometriosis community, and I started off like so many of us as a patient myself. And so, like so many others, I suffered a delay in diagnosis. I felt the symptoms in high school, was diagnosed with IBS, anxiety, everything but endometriosis. And it wasn't until I started my fertility journey that I was eventually diagnosed with endometriosis. But again, like so many other folks, the surgery I had with my reproductive endocrinologist was minimal. He left the majority of the disease. I wasn't explained what happened. And then that sort of led me down the road to finding just a better way to feel better. I was just suffering, just undergoing a lot of different pelvic surgeries until I finally learned what endometriosis was, found an excision specialist, and then started really learning more and more about the disease. And I'm also wear the hat as a mom to a teenager with endometriosis. This is me and my now 18-year-old. She had extensive excision surgery when she was probably like 14, 15 years old. So I also wear that hat of, understanding really, like, not only as a teenager myself, but also seeing her go through it. And also, even though we had so much more information, seeing her, local OBGYNs, dismiss her and, go through that process with her. I also wear the hat as a patient advocate. I've probably been in the advocacy community for the last, like 15 years now. And my advocacy has changed so much throughout the years. And I think, the organizations that I first worked with when I first became a patient advocate aren't really the same organizations that I work with now. And um, I'm really grateful for connecting with the patient-led organizations like She is Lotus. And also I'm grateful to my mentor again, Heather Godone, who is here, who really helped me have a better understanding of the systemic obstacles that were harming patients, that were really stopping care, that the system is built this way, and just really like all of the harm it was causing. So I'm really grateful to be a patient advocate and then to learn and be inspired from other patient advocates in the community. I'm also a mental health provider, so I'm a licensed clinical social worker. So, as a licensed clinical social worker, I help patients with a lot of the mental health impact that endometriosis and infertility, pregnancy loss, chronic illness has. I think, as we all know, endometriosis is associated with depression, with anxiety, also with a lot of medical trauma because of the systemic harms. So, as a mental health provider, I hold space for that. And I feel like it goes hand in hand with patient advocacy, because if you are not helping and working in collaboration with others to change the system that's harming patients, then, you know, things that are causing grief and depression and anxiety are going to continue. So I really believe that, you have to show up like in so many ways, because there are so many obstacles for patients, and I'm grateful to be a part of the community. Okay, so contents of the 2011 ACOG bulletin. What I did was I I kind of like went through the bulletin and picked out lines that I felt were especially disastrous. I think we all know and feel in our bones how the healthcare system has impacted us as patients, has impacted our bodies, our livelihoods, our capacity to work, our capacity to go to school, our fertility, our organs. I mean, just our mental health, the list goes on and on. And it's sort of jarring when you see the standards of care. So the ACOG is the American College of Obstetricians and Gynecologists, and they are the organization that your average OBGYN pays dues to. It's their professional organization. And what I want to make clear is that the ACOG considers itself a leader in women's health care. And what's really important is that they represent the doctors. They really have the provider's best interest at heart. And they would argue that providers have our best interest at heart, but I don't think anyone has our best interest at heart more than us, if that makes sense. So, what we have found, those of us advocating for a long time, is that if our interest and the ACOG's interest align for them professionally, financially, then it's really good. Like, then we're good. But when patients have challenges with care, and obviously we see that across the board. We see that with IUD insertions. There was just an uproar from patient-led uproar that, wow, like, folks need anesthesia, like, when, or more pain medicine when having an IUD inserted. Or obviously the crisis in healthcare for Black women giving birth, and the mortality rate. There are so many problems like with the ACOG, and yet it is impenetrable to try to for patient advocates to try to fix those problems because they feel like they are fixing the problems. So but there are still problems. But anyway, I'm getting ahead of myself a little bit. But I really want to pick out some lines that when you read it, you're gonna be like, oh, like, yeah, like these lines really impacted me. So the first thing I wanted to bring up is that ACOG in the 2011 bulletin, which I think was written in maybe 2010, in any which case, it talks about well, first, the definition of endometriosis is wrong, which is really disconcerting because it is a practice bulletin. So they define endometriosis as a chronic gynecologic disorder whose principal manifestations are chronic pain and infertility. I feel like, well, okay, let me keep going. Principally associated with attachment and implantation of endometrial glands and stroma on the peritoneum from retrograde menstruation. I feel like also there are probably a lot of advocates in here that are just cringing when they hear this because right? Like the mentioning of retrograde menstruation, the saying that it's endometrial glands, when endometriosis is endometrial-like and it's pathologically different. So that's like really problematic, and that leads a lot of the care and the treatment or the lack of care that you'll see. I also, they mention chronic pain and infertility, which really tells me that they're looking at it from a reproductive lens. I feel like historically, for reproductive health, there is a lot of paternalism in medicine where they focus on, fertility. And I feel like endometriosis care, like unless you're trying to have a baby, there's just a lack of interest or care in how the disease is impacting you. And then, of course, if you're done having a baby, well, okay, I'm getting ahead of myself again. Sorry. Okay, so that's the definition, and it's a wrong definition. And it sets the stage for just poor care. They talk about it as women of reproductive age. And I feel like doing that really you leave out so many patients. You leave out transgender patients. You leave out gender diverse patients. You leave out patients who before they have their period, where we know like research shows that there have been people who are symptomatic. You also leave out postmenopausal patients. So just right there alone, you leave out so many patients, and it's a very narrow scope of the disease. It says here, no particular racial predisposition, which is very vague. And for a long time, and probably even still in some places, endometriosis is seen as, or has been seen as a white woman's disease of women who, because of working, prolonged their desire to have babies, and now they have this disease. So I feel like not addressing, it's a missed opportunity to show that endometriosis impacts people of all races, and then also a missed opportunity to talk about how racism impacts care. So again, like I feel like it's a bulletin fail. And then when you talk about treatment, I feel like things get just significantly worse. So let's see. Sorry, I need to move my face around the screen to read. Okay, so the treatment really is kind of set up for patients to fail. So they talk about how after an appropriate pretreatment evaluation to exclude other causes of chronic pelvic pain and failure of initial treatment with OCs and nonsteroidal anti-inflammatory drugs, empiric therapy with a 3-month course of GnRH agonists is appropriate. So in the former bulletin, they talk about medical management as like birth control, and then it says, you know, when that fails, which we know that eventually birth control is going to fail because it doesn't treat the actual disease. It can minimize symptoms for some. So they talk about a GnRH agonist, which again doesn't treat the disease either, but again can minimize symptoms, but also has significant side effects which are not mentioned in the bulletin. They talk about surgery. They're very like, they mention excision, but they mention it. They say the value of excision of deeply infiltrating endometriosis solely to improve pregnancy is unclear and may adversely affect fertility. I mean, we have research that now shows that excision can help fertility. And, you know, that for some folks who have excision surgery, it can improve fertility, natural fertility, but even for those who need to have IVF, excision can be really beneficial. But again, it again focuses on fertility and doesn't even talk about, say, the benefits of excision for organ restoration, for quality of life, for ability to work. So, you know, that is really upsetting. And then, you know, again, it talks about if the initial therapy fails with patients with suspected endometriosis, a diagnostic laparoscopy to confirm the presence of endometriosis may be offered. So really in this bulletin, they say, okay, well, I guess if medical treatment fails, which it does fail, right? Like we know it fails because it doesn't treat the disease, then you can do a diagnostic laparoscopy, which so many of us have had a diagnostic laparoscopy. I had a diagnostic laparoscopy, and that means a lot of the disease is left. It doesn't mention treating the lesions. It doesn't mention like excision. It doesn't mention going to an expert. It doesn't mention, you know, look at the symptoms first to see maybe like how extensive the surgery is going to be. Nope, it just says, well, diagnostic laparoscopy just to confirm disease. So that is really unhelpful, and for patients that is horrific because we spend time and money and there's medical trauma in going through these surgeries that are ultimately not helpful. And then the worst part of the bulletin was when medical management has failed, which research shows it fails, then it says undergoing definitive surgical management is appropriate in those who do not desire future fertility. Hysterectomy with bilateral salpingo-oophorectomy often is regarded as definitive treatment, definitive therapy for the treatment of endometriosis. So again, medical management, which is going to fail. They do, you know, GnRH, which again has a lot of side effects, doesn't treat the actual disease. Oh, maybe a diagnostic laparoscopy. Let's just see if it's endometriosis. Oh, it is, but we're going to leave like most of the disease in. And then when all of that fails, which it's going to fail, then they're like, well, let's just do a hysterectomy. Like, and that's the definitive treatment. Now, I have fibroids, or I had fibroids and adenomyosis. So for me, a hysterectomy was very important for my quality of life. I was done family building. And so especially for the adenomyosis, I really felt like a hysterectomy was the right choice for me. But it certainly didn't treat my endometriosis. I got excision surgery at the time of my hysterectomy. So, you know, patients who go so long and so much pain, their doctor says, well, let's do a hysterectomy. And that'll like help your endometriosis, even though endometriosis in of itself is defined as, disease outside of the uterus. So this practice bulletin essentially directed the hysterectomies of so many patients over the years, even though it is not indicated for endometriosis. So this bulletin, really, really terrible. Again, and I kind of went through this. By the way, I picked like a sort of like, it was like social justice and the environment Canva slideshow for my presentation, and just sort of like randomly stuck endometriosis nonprofits on the people. So I hope that's okay. That's why you'll see that. So what did that bulletin mean for patients? It meant that, the wrong definition of endometriosis indicates wrong treatment. When you think it is the uterine lining, then of course you're going to think, whoa, hysterectomy, like let's, give them drugs that put people into menopause. So really within the first paragraph, it set the standards up for failure, which meant more harm for patients. Again, white women of reproductive age get most recognized, which is horrible, and again, like causes medical trauma and harm for the BIPOC community. The value of excision was questioned, and I don't know for any of you, but I know when I would go to other when I'd see my OBGYN or my reproductive endocrinologist, when they heard that I went to an excision specialist, one doctor said to me, like, oh, like those people are butchers. I can't believe you went to them. So I feel like the system sets up this fear just because people are uneducated. Diagnostic laparoscopy isn't helpful. GnRH treatments, again, offered, but doesn't actually treat the disease. And then hysterectomy. So this is the endometriosis treatment merry-go-round, and it is a mess, and our bodies are in crisis, and we just go from failed treatment to failed treatment, and in the process lose so much of our resources, our energy, our time, our physical health, our mental health, our fertility, our capacity, our autonomy, our hopes, our dreams, our desires. And this happens for decades because we suffer from often, again, before period to postmenopausal, and it is really atrocious how endometriosis patients have been treated. And from working in the community for so long and just having the blessing of working with advocates all over the world, I know that our situation in the United States is reflected in patients really like around the world. Okay, so before we get to the new bulletin, I'd love to talk about all of the advocacy attempts. I have a picture of Sisyphus, which is a character who in vain just pushes like a large boulder up like a hill and often gets crushed by said boulder and then just continues to push the boulder up the hill. And I feel like advocates in the room, you understand this metaphor. This is our life. This is sort of what we do. And I hope you don't mind. I need to cope with this with humor. So there is some humor in this presentation, or else I think we're all just going to sit here and cry. Okay, again, I'm explaining this, but it was not something I did alone. It was something I did in collaboration. So before we get to the new bulletin, we're going to talk about some advocacy attempts, again, since 2017. Go get Heather's book, like, one, because the chapter's awesome, but two, like, you'll get more information. So we realized how all the standards of care were harming patients. We just talked about all those reasons. And then we thought to do a petition to update standards of care and to update coding. And so we created a petition, and that was in August of 2017. And we sent it out. Again, like had wonderful like social media partners and patient collaborators. And I'll show like a picture of the petition on like the next slide. And so the petition ended up getting, I think it was over 6,000 signatures, and a lot of doctors signed it. AAGL, some board members at AAGL signed it, and really advocates from all over the world signed it, multidisciplinary experts, patients, because you know what, like when it comes down to it, we're all in agreement all over the world that endometriosis care is awful and causing so much harm. I think one of the most meaningful parts of the petition for me was hearing patients had the option to write their stories of why they're signing this petition. And there were really sad stories of patients saying, like, I could hardly finish high school. I lost my fertility. And then, like, really devastating, I lost my kidney. I, had to drop out of college, like all of these things that I know we all can relate to. And then some of them, one person, I'll never forget this, was like, my hairdresser diagnosed me with endometriosis when my doctors couldn't for 10 years. And I was like, yeah, that's so true. Like, I think we all can relate to that. So I found the petition to be like particularly like moving and unifying at the time. And, what came of the petition was, well, so, and again, like you'll see pictures, we ended up, like a group of us ended up, actually, let me see if I could, okay, yeah. So again, here is the We Met Our ACOG. That was like part of the patient protest that followed the petition. What happened with the petition is, I guess we got enough buzz, or at least I feel like maybe ACOG got embarrassed enough that like they felt like they had to do some damage control. So they reached out, and I huddled again with other key advocates and in preparation, because the VP at the time was like, oh, like I'll talk to you. And so prepared for the call, and he ended up saying like, oh, why don't you rewrite the bulletin from a multidisciplinary point of view, which that was a little crazy, but you know what? We did it, and I think it's there. Heather and I did it. It took a very long time. And what we did was we dropped a little present off for ACOG outside of their headquarters. And it said, ACOG, endometriosis patients are watching. We did that like right in front of their window, and like, put bows. And so, handed in like this bulletin that took us like, I mean, we did it quickly, but it took many hours to write. And, unfortunately, like nothing really sort of came out of that, even though we had spent a lot of time, and he said to do that, and in the rewrite, again, we just defined it correctly. We talked about excision. We talked about multidisciplinary care. When they sort of didn't get back to us, then we decided to do a patient protest. And again, you can see it was in collaboration, like with other organizations. We did it for the following March. And you could see a picture of us. Again, we went outside the ACOG headquarters. It was freezing. I feel like both times it was freezing. I'm grateful Heather bought me gloves, I think, like at CVS, which was down the block because we were all so cold. And again, like we protested, made some noise, and ACOG came out with like this random statement that was like, we appreciate patient advocates, but also we're awesome at endometriosis. It was some sort of like crazy statement. Um, so that sort of like ended there, and then they reaffirmed the bulletin. I feel like in like 2018 or 19, they just reaffirmed the garbage bulletin from 2011. So that was not good. Um, and then we had another opportunity to, which we thought was maybe like hopeful. We had sort of connected with an endometriosis and excision surgeon who was also on the ACOG ethics committee. And it was me, Heather, and Jenna Reish. And she was like, listen, if you give us a bulletin of bullet points, I will like hand it directly to the people who update the bulletin. Like they're going to work on it. It's going to be great. And we're like, okay, so we're really diligent. So the three of us, and I know Dr. Arrington like helped as well. The three of us like worked really hard, and we handed in this like 5-page paper, and she's like, can you actually make it like shorter and maybe nicer? And we were like, okay, all right. So what we try to make our trauma like really palatable, because that's what we were told to do. And yeah, we came up with this bullet point list, which you can kind of see here. And it talked about like, dear ACOG, please define endometriosis correctly. Can you further clarify that hysterectomies actually aren't a definitive treatment? We asked them to talk about excision as beneficial and not harmful. We asked about, clarification about hormone therapy, medical management. We asked for them to talk about multidisciplinary care and a culture of referral and expertise. And then we also asked them to talk about health disparities. We want to talk about how racism impacts care and, how marginalized and minoritized, sorry, marginalized and minoritized communities suffer more medical trauma and more harm, diagnostic delay, just really including Black women under treatment of pain, just more prone to having a hysterectomy for benign conditions. And so we asked them to take care of that. And we also asked them to talk about the impact of care like on transgender patients and gender diverse patients, and how often there's more delays to diagnosis and there's a need for more research and more understanding and more trauma-informed care. So we handed that in. And we were, maybe pretty excited about that. That was in 2019, maybe. Let me see. I think I wrote it down. Yeah, like 2020, maybe 2020, or 2021. In any which case, I could tell you how that went. We were ghosted again. Didn't hear back. So it was pretty defeating because, as patient advocates and patients ourselves, we understand the impact of this bulletin. We understand like the harm and the trauma that it is causing patients. So just really defeating how the system is just set up in a way that experts know that patients are being harmed. We obviously know that we're being harmed. And yet, like, there's no seemingly inroads, like, to change things. So anyway, yes, continue to get ghosted. So kind of leading up to the bulletin, the new bulletin, it was kind of like random. I have a high school picture because in high school, my high school bulletin, like I realized that the new president-elect of ACOG is went to my high school. She's a few years older than me, so we did not know one another. But I was like, huh, that's interesting. And so definitely reached out and, again, talked to Heather, talked to Jenna, talked to Lauren Cornegay from Endo Black. And we sort of strategized to try to see if maybe this meeting, this connection could actually, I don't know, something could come of it. But again, like we weren't holding our breath. And so we again handed in the bullet points. We handed in the revised practice bulletin, laid out like, different things that patients have been hoping for. And without any really comments back, except yes, this does seem to be a problem. Wouldn't you know, like we see on social media that ACOG released new bulletin, new diagnostic bulletin. So what I'll do now is go into the new bulletin. I think it's really important to note that the other bulletin, it says specifically that this bulletin replaces the other bulletin. So as far as I'm concerned, that bulletin is like the merry-go-round on fire. Like it is out, it is done. It is no longer viable, at least in my mind. I think it's curious that they've done a diagnostic bulletin and not include treatment, which again is getting some criticism. But I'm going to talk about what the bulletin says and then sort of like try and give like a fuller picture. Okay, so what I thought was like really good is that they got the right definition of endometriosis. So that's really good. A lot of criticism is like it's a low bar, and I'm like, I mean, maybe, but also like this is really important. So it says that the new definition is endometriosis is a chronic inflammatory estrogen-dependent disorder defined by the presence of lesions of endometrial-like tissue outside of the uterus. The condition can affect multiple systems in the body, causing pain, infertility, and decreased health-related quality of life, sexual satisfaction, and decreased work productivity. What I really like about this definition is that it doesn't tie it back to the endometrium. It doesn't mention Samson, although I think Samson is mentioned as a possibility, but there are other possibilities. So I think that's like a step up. I like that it doesn't focus on infertility. I like that it says it is multi-systemic in the body and that it causes inflammation. So to me, I feel like that was a really positive change. Another really positive change is that it talks about the disease pre-menarchal to post-menopausal, and it includes adolescents. Again, that's huge, right? Because when you think about patients who are dismissed, you have postmenopausal patients going in saying, like, I have all this pain, could it be endometriosis? And often they're like, no, you're all done. Like you don't get a period or you've had a hysterectomy. It can't be endometriosis. And then also it recognizes disease in younger patients, which again, patients who go 10, 20, 30 years not being treated and diagnosed, and then just getting a diagnosis earlier can make such a difference. So I think that's really important. It talks about how individuals from minoritized and marginalized communities may face additional barriers to diagnosis, delayed diagnosis and treatment. I think that's really important. And they go on to also talk about specifically how Black women have a harder time getting diagnosed than white women, and they spell out because of racially biased medical care because of racism. And I thought that was a really, really important advancement in the bulletin. It even talks about the undertreatment of pain of Black women because of racism. And it talks about just the more difficulty in getting treatment and the misdiagnosis. That is huge. That is really like a big deal. They also talk about, again, a really big deal. They added people assigned female sex at birth who identify as transgender, men or gender diverse may face additional unique barriers when presenting for endometriosis care. Again, huge historical, amazing that that is included, like in the bulletin. Um, there are other things that I I really like appreciated. It talks about negative imaging findings do not eliminate the possibility of endometriosis, nor does negative pathological findings. I think what a lot of patients come up across is that, they go for an ultrasound, they go for an MRI, and it's like, well, negative, nothing's wrong. And so I think there have been criticisms that, there are folks who do incredible work with ultrasound and pelvic mapping, and I would say the majority of radiologists and even doctors like in the United States don't understand that yet. So I think it's very important, like if we're talking about harm reduction, to spell out negative imaging does not mean you're okay. Negative imaging could still mean endometriosis. If there is a surgery that is done, and they don't find anything, it doesn't mean you don't have endometriosis. They actually spell out it actually can mean that the clinician missed it. They spell that out. So I think that can also reduce harm. It says here, diagnostic laparoscopy should be performed by a clinician with training and skills in laparoscopic surgery for endometriosis and should include a systematic inspection of the pelvis and abdomen and documentation of intraoperative findings, including the appearance, location, stage, and extent of the disease. So again, this is the first time in the bulletin where they talk about a clinician with training and skills in endometriosis. And so they also say here, patients with physical signs suggestive of deep endometriosis involving the bowel, bladder, or ureter, such as thickening of the posterior vaginal fornix or nodularity of the uterosacral ligaments, should be referred to a clinician with expertise in the surgical management of endometriosis. Suspected endometriotic lesions should be treated at the time of initial laparoscopy when possible to help avoid the need for additional surgery. I think that is really important. It wasn't in the other bulletin. And I think spelling that out is like gonna again like reduce harm for patients. So as you can see here, like we put out a celebratory post. Lauren posted it from Endo Black, and we all collaborated, and it was again Endo Black, Heather from the Center of Endometriosis Care, myself, Shannon from Project Endo Global, and Jenna from the Endometriosis Coalition, because we really have been trying for years to get this done. And so we celebrated because it's a proper definition of endometriosis that encompasses all systems in the body and other health impacts. The acknowledgement that it is a lifelong disease, again, I think is historical. The acknowledgement of the harm that racism has on care, particularly for Black women. The acknowledgement of the challenges transgender and gender diverse patients face. The acknowledgement of the need for referrals to experts in surgery and treating all disease during diagnostic laparoscopy. the removal of hysterectomy from guidelines, the inclusion of extrapelvic disease. I didn't show it here, but they talk about disease on the sciatic nerve. They talk about the symptoms of thoracic endometriosis. They talk about, really all the systems on the body and the different symptoms that go along with it. The emphasis on patient-centered care and the harms of diagnostic delay. The emphasis on not only fertility, but on other quality of life indicators that I really appreciate as well. The knowledge that negative imaging and surgery does not mean patients don't have it. So I thought these were all like really helpful. Let's see. Oh, I didn't read. Okay. So one of my favorite lines, like from the bulletin, was physicians can facilitate earlier diagnosis of endometriosis and improve patient satisfaction with their care by applying a patient-centered approach that includes validating patients' symptoms and experiences, demonstrating sensitivity, respect, and compassion, treating patients as partners and experts about their own bodies, communicating clear, accurate information about the condition, and providing a prompt referral to a specialist. Wow. Wow. If we all got that sort of care, we would just be in a much better position. Okay, so to go over not everyone celebrated. Not everyone celebrated. There were folks on social media like really having a hard time with it and criticizing it. And I really feel like it's sort of like these things. I don't know if you remember, that big thing on the dress. Is it gold? Is it blue or black? And then also, like with this picture, like, do you see a vase? Do you see two faces? I don't know. So it was funny to me how folks really really had a lot of negative things to say about it. I think again, beauty's in the eye of the beholder, and maybe a criticism is that it wasn't clear enough, right? And I think this is just a small part of many things that have to change in order to and improve for patients to not undergo medical trauma and to get the care that we need. But so a lot of people are taking this bulletin as like, you don't need surgery like to get diagnosed, and let's just give patients more birth control. So that's a problem, because endometriosis needs to be removed, like by an excision specialist, for patients to get relief, along with other multidisciplinary care. So, some of the takes were, well, like if yes, we could diagnose endometriosis clinically and then just give patients birth control and spare them from surgery. I don't really, what I took from my interpretation of the bulletin is that it said you can offer patients medical treatment to try and minimize symptoms, but also like while being referred out to a specialist, because they did say that. That's how I'm going to interpret the bulletin, but unfortunately, I don't think everyone is going to interpret it that way. So I think what I like about the patient-centered care is that it is the patient's choice, but also they have to be aware of all the choices and they have to understand what it means to be referred to a specialist. And so again, like I feel like we have a lot of work to do, but to boil this diagnostic bulletin down to just that line, I think does it a disservice. These are just some of the folks who, if you want to learn more about the criticisms, people said they were mad. People said that, they just had like a lot of things to say. But again, like there were so many like hopeful positive, important things that came out of this bulletin, that I feel like, again, to boil it down or to sort of not understand the historical things that happened, again, I just really feel like is a disservice. That being said, ACOG is still problematic. Like, ACOG is still really problematic. And so we can talk about, I could talk about for days how ACOG is still problematic. There's no plan of action how to implement these changes. They didn't officially include patients or multidisciplinary care experts in these revisions, even though I feel like our work was included. But the fact that, I just had this vision of like ACOG in a tower and us sort of like shouting up to try to like, really beg them to spare our bodies and our minds from the harm they're causing us. And like, they either wouldn't hear us or would throw our work back at us, and we just kept shouting up. Like, it shouldn't be like that. Um, while we're grateful for updates on diagnosis, which hopefully will reduce harm, how is ACOG working with other orgs to make multidisciplinary treatment accessible? How are they going to, educate their members on some of the great lines, like in this bulletin? The way advocates were treated throughout the process, was reprehensible. And I can joke about it, but it really was terrible. And then how does ACOG atone for all of the medical trauma they have caused? How do they account for all of the, folks who've lost their kidneys, all of the folks who've lost their fertility, who've lost their livelihoods, and honestly, like who've lost their lives to this disease due to gaslighting and trauma and impact on mental health and like lack of supports and lack of referral. How do we come to terms with all of this? I think there needs to be better accountability and also like a promise to collaborate with patients in a true and meaningful way. What can other groups learn from this? Advocacy ages you. I think that's really all I learned from this, is that it really ages you. Although I feel like everyone on this Zoom is an advocate and understands that as well, and you feel like you've probably been aged in the process. I don't really think, I mean, it was it was chaos. Like how all of the attempts, everything like is pure chaos. Like this, yeah, should not be modeled. Like, and there needs to be a big change. But I think honestly, like what can be modeled and what I appreciate and respect is, and in all seriousness, I think what I learned from this and I'm grateful for is collaboration is key. Man, am I so grateful for the other patient advocates and patient leaders who are running nonprofits, who are tirelessly working throughout so many different systems to create change. And I think that is what is most important, is that we all have to stick together. And when you meet someone who, and an organization who puts patients first, who isn't about ego or isn't about like what money they're making on the side, or like who really just is giving their all out of the desire to reduce the harm that others feel, I think is so important. So, I've sort of like put up some like there's a reproductive justice research and action panel that's coming up. I think it's next week by some incredible advocates. There's me and Heather out in one of the cold days in front of ACOG. This is other folks. You could see Mariella from Layla, like she and Wendy was also there. There's just like a lot of advocates who came out like to protest ACOG. So, and then also Lauren's roundtable, I heard was phenomenal. And, um, you know, and then Shannon also like showing below the belt in over 40 medical and nursing schools. I really think these are the things that are really gonna continue to push care forward, and it is what has pushed care forward always, is this like really fierce patient leader collaboration. And I am so humbled and grateful to have a lot of these folks as my friends and colleagues and just people I admire. I feel very lucky that I get to interact with such incredible people on the daily. Okay, so where do we go from here? And I want to talk a little bit about, I think where after this ACOG thing, I really feel like the next step is really making sure that patient advocates and patient nonprofits, like She is Lotus, like Endo Black, like Heather, are are actually like at the table and meaningful stakeholders. There is a study availability of region-specific endometriosis care guidance, a global scoping review, and from reading the study, my interpretation of it is that, and this is kind of what we're seeing, is that, when you work together, and I feel like I was just in Connecticut last night, and, Heather could probably speak more to this at Endorise and the Endometriosis Connecticut Working Group. It's really like when you get people all together, the government, nonprofits, patient advocates, important stakeholders, the medical community, when you get everyone like working together, then you can make like real meaningful change like within the system you're working in. I don't think the answer is, making global endometriosis recommendations, right? Because, what works in New York City, may not work in rural Ohio, which may not work in Switzerland, which may not work in other countries. So I think it's really important to have patient advocates like at every level, as well as, folks in, all the stakeholders like they did in Connecticut to really create meaningful change. There is, Shannon posted a national standard for endometriosis care. I wanted to mention it. I don't, um, I'm grateful for Shannon's involvement, and also I don't know like what the plan is for that, or how they're going to implement it. And so, but I thought it was interesting that there are different organizations a part of it, um, in terms of like medical organizations. But there did seem to be a lack of, other patient-led nonprofits, especially those that are representing marginalized and minoritized communities, which again, like I feel like it's really important that everyone like is able to have a voice and have an opinion and be able to direct care. I think what I do know for sure is that the days of ACOG setting standards and everyone having to abide by those standards and patients not being able to question those standards or change those standards, like that is a really paternalistic way of guiding care, and it's really crazy because in the same breath they're like, your body, your choice, and women's empowerment, and we empower women. And it's like, well, if you really empowered us, you would stop harming us and listen to us that you're harming us, and you would give us autonomy over our care, and at the very least collaboration. So I think, as always, there's a lot of incredible work to be done, and I'm just grateful to be a tiny part of it and just to work along with other advocates who continue to inspire me.
Awesome.
Oh, sorry. Oh, sorry.
Go
And
ahead. Yeah.
there's my book. I wrote a book. It talks a lot about systemic harms, impact on mental health, physical health, and there's my information if you need to see me.
Awesome. Thank you, thank you, thank you so much, Casey, for that wonderful presentation. Really going over everything. Down, like, 'cause I don't think a lot of people understand the history to it all, and what it took to get us to where we are today. Is it perfect? I mean, but is it progress? Yes, absolutely. Absolutely, 100%. I want to thank Heather for joining us and being in the audience today. I also want to thank Julia Mandeville for joining us as well. When we started off our talk this evening, we gave two questions to spark some conversation in the chat. The first one was, for those comfortable sharing in the chat, what is one thing you wish healthcare providers better understood about living with endometriosis?
Yes.
And another one was, what helped you most in coping with endometriosis? Support groups, family, mental health care, advocacy, or something else? So I'm going to go ahead and read some of those responses, and then we'll open it up to a broader conversation. Ethan says, what I wish providers knew. Endometriosis is a full body disease, and connecting with other inflammatory symptoms, biggest coping strategy, endo and chronic condition community. And then Marielle says, better and more extensive, wider pathology samples to be taken from multiple areas, not just where there is clear pathology visualized. I think that would be helpful in the surgical arena to aid in patient care, taking those samples from all over, not just one area. That's my answer to the aforementioned question. Oh, and for the second question, what she said supports the most, advocate and educate, help and participate in my own care, being involved in my own care. It helps to have better informed care and better sense of autonomy. See if there were any, lots of commentary as we went through. I think we all really enjoyed some of the visualizations, being ghosted and Sisyphus and the tower and all the others. Everyone, then it turns into a little bit of a love fest. Everyone, you inspire me, you inspire me, I love you, I love you. um and everyone's saying the book is amazing. At the end, we are going to be doing a raffle. If you are in St. Vincent, please put in the chat that you are in St. Vincent. We are going to be doing two raffles if we have folks from St. Vincent in with us. And the fire carousel was very good. The fire carousel was very, very good. I think we'll open it up to any commentary, and then I will hand it over to Odelia for more of a structured Q&A. You can either put it in the chat, your comment, or come off of mute, whichever you're more comfortable with.
And one thing I wish healthcare providers better understood, not just about living with endo. For me, it's what I wish they understood. A lot of them are still following ACOG's old guidelines and the belief that a hysterectomy or getting pregnant kills your endo, and that narrative is still being pushed. I'm not sure what it is like in the States or elsewhere, what I could speak about here. That is the narrative being pushed. That if you have endo and you've had a hysterectomy, then the symptoms you're experiencing couldn't possibly be from endo. You must have something else because the source of your estrogen is gone. I've heard it all. So I wish they understood that those things don't cure endo. And what has helped me the most is community, is finding this community, becoming an advocate myself, and being empowered to speak up for myself as well as for others who haven't yet found their voice.
Julia, I see your hand is raised. Go ahead.
Yes, thank you so much for this wonderful fireside chat. Hey, Casey. Um, what I wish providers would recognize, just to build on Adelia's point, is um, I think especially in the Caribbean, wanting to have multidisciplinary, interdisciplinary care and referrals is not questioning your skill set as a provider. It's just recognizing that this might be, again, this is patient-centered care, right? We know you're smart, we know you're skilled, you got the degree, but this might be outside of your area of expertise, and that's okay, because at the end of the day, it's about the patient and not your ego. So I think that is something that I think we need to address within the region. But I can say, for instance, in Barbados, more people are starting to refer out, but not as many as we would like. But we're going to get there. And what has helped is honestly, again, being able to vent to people that know what you're going through, and also recognizing that even though the progress has been slow and sometimes it is frustrating, and we haven't been around for as long as Heather and Casey, but we know the barriers we have to face in the region. There is still some momentum, and there's still interest from the powers that be, and so that it has been heartening to me. And yeah, thanks.
I absolutely agree. Everyone who is here tonight um, has played a special role in my journey, not just as a patient, but as an advocate. And I appreciate and love you guys so much. I had to say that. Odelia, if you want to go ahead with the questions.
Yes. Casey, I have a list of questions. I don't think we're gonna get through all, but I sent them to to Liz and Kimet earlier because I'm like, Casey's here, captive audience. I can ask anything I want. So, question number one. In the book, you share your journey as both a clinician and an endo warrior. How has living with endometriosis shaped the way you support patients in your professional work?
I think having gone through the delayed diagnosis, feeling hopeless, going through the grief, the loss, the frustration, I think just adds an extra layer of empathy and understanding. And I think sometimes it just gets getting to like the processing and the adapting and the clinical work sooner, because I don't have to catch up. Even though everyone has a different experience, there's less catch up to do on, say, if I'm working with a patient who has say like a rare type of cancer that I don't know about. With endometriosis, there's just this level of understanding that I think we all share.
Yes, I can see that. Second question. With the new ACOG guidelines highlighting a more comprehensive approach to endometriosis care, what role do you think mental health support should play in the standard treatment plan? Because yes, they're recommending this multidisciplinary approach, but I'm not seeing any bullet points as to what this multidisciplinary approach should look like. So, as a mental health practitioner, what role do you think mental health should play in that multidisciplinary care, and how can we advocate for, well, advocate maybe more or differently, or I'm not sure how we can get them to acknowledge and see the importance of adding that to the treatment plan.
Yes, I think that's such an excellent question. They did sort of throw out multidisciplinary care, did not explain what that meant, did not include mental health or pelvic floor therapy or other things that I think we would have hoped that they included. I think mental health is tricky because I think there's still a stigma to mental health. And I was on, there's a group in London that does like lunch and learns every month, and they had a psychologist on. And one of the doctors said after her presentation that he felt awkward recommending mental health to patients. So I think it's fighting that stigma and keep talking about how important mental health care is, and how I'm grateful for the researchers who talk about the impact of endometriosis on mental health, because I think doctors love research. Shout out to Julia, who's here and does like phenomenal research. I think healthcare providers are more open to listening when you have research. So I think continuing to present our case, continuing to reach out to providers. I routinely will reach out to providers and with the patient's approval to see if they want to collaborate and work in a multidisciplinary way. And I think within our own mental health organizations, to like, I know for kidney care, there's a whole section of social workers who work in kidney care and dialysis. So I think making the case that, again, like folks are trying to do for endometriosis as a subspecialty in gynecological care, doing that for mental health, I think is really important. So, maybe having organizations dedicated to endometriosis and mental health, having conferences, and just really starting to organize around it more and more.
Okay, thank you. As I was listening to you, it just reminded me of I've been thinking about since I started reading the book and my own experience and journey as an endo warrior and a therapist. Before diagnosis, I had spent my years, working with persons in our psychiatric hospital, both inpatients and outpatients. And now, because of my experience, I am finding myself transitioning to working more with persons, mostly women, going through life transitions like endo, adeno, PCOS, fibroids, infertility, miscarriages, etc. And because, as you said, of my own experience, it's easier to get through to them. It's easier for us to build a rapport, and they see that somebody understands. And I've been starting to get doctors now referring women to me. And I had one lady tell me, I didn't think anybody else in this country had it. We're such a really we're like a dot on the map, like a grain of sand. And for you to think that you're the only person to have a condition, you're the only person who is experiencing all of these symptoms. That was like, I felt sad because I had felt like that when I was first diagnosed. And Julia was actually the person who helped me through that whole process. The internet sent me to Julia when I was first diagnosed and was looking for anybody that looked like me and sounded like me who could understand, because all I was seeing was America, England, France, so on. So I'm like, I can't relate to your experience because I don't have these resources available to me. I don't have an excision specialist here. I don't have X, Y, and Z. So being able to find somebody who had a similar experience to me and from the same cultural context as me was so empowering and helped to sort of push me into that space because there was nobody in my country doing that. And so I find myself slowly transitioning over into doing this sort of work. And it actually inspired my dissertation. And I wrote it on endometriosis, mental health, and quality of life in Caribbean women. And yet my sample size was small because it's a dissertation. But I think what came out of it was so powerful with and almost every woman talked about the lack of multidisciplinary care. That you go to one doctor and you feel, okay, so I have endo on my lungs. Where do I go from here? I, I have, because of endo, my relationship with my partner isn't going well. Where do I go from here? And so even from that small sample size, you could start to see it. You could start to see the themes coming out about the need for multidisciplinary care. But when doctors are going by the book, okay, ACOG said dot, 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 and they're going by this checklist, and then they see multidisciplinary care, it's left up to their interpretation now, what that means. And I find a lot of doctors aren't thinking about the quality of life impacts and the mental health impacts. So here we are all struggling um, because the same medical system that is treating me is the same system that has traumatized me. And so all of that has just been on my mind recently, and I'm just trying to figure out, what direction to go with it in this little dot on the map. But it is such an important conversation to have, and persons like you and Heather who have brought us this far. And, it's not that the community is growing. We have so much further to go because there's still so much missing from this ACOG guideline. We are thankful that there has been some progress, but there's so much more to be done. And I don't know, our energy levels right now, but the heart is there to do it. Because when I think of my own experience, I don't want any other girl or woman to have to go through that. So that takes me to my next question for you. How important is community, whether that is support groups, advocacy organizations, and peer networks, in helping people with endometriosis navigate their journey?
I feel like I just need to take a minute because everything you said was so incredible and gave me chills, and just the idea that when you said the system that traumatized us is also treating us, like, oh, that I feel like I just need to reflect on that. Like, I'm gonna take that with me. That is such a powerful statement. And I also just wanna congratulate you on your doctorate and also
Thank
say
you.
it sounds like you're such a gift. I know you're a gift in not only the greater endometriosis community, but those patients that you are seeing, you are fulfilling like a need and a gap in care. And so I just want to say, like, I'm really touched by everything you just said. And in terms of community, I'm grateful for this community this evening, like that we're chatting. I feel like when you were talking about, I often have patients come in my office too. It's like, I don't know anyone else with endometriosis. And there's just like a comfort in being in community with someone else who understands. My first endometriosis meeting, I was so desperate. I didn't know anyone in my life with endometriosis. I went to I think I found it on Facebook. I don't even know. It was like so long. It was like probably like 15 years ago. It was so long ago. I must have saw something online. It was before I was on Instagram, where there was like this meeting, Ender Warriors meeting, and it was started by Jill from Ender Warriors. And I like lived in Yonkers, went down to the New York City, went to this apartment. Like I was like, I hope I'm not going to get murdered. Like I have no idea like if Jill is real, like what is happening, but I'm so desperate for community that I'm gonna go to a random apartment in New York City and like knock on the door and like open the door and it's Jill and it's April Christina, and those were the two first people like I met with endometriosis, and we had like a small endo warriors meeting in Jill's apartment, and it just was life changing to me to be. I love April too, to be in that community. So I think endometriosis causes anxiety, depression. There's
Yes.
so much isolation. So that connection, like that connection you talked about finding Julia, like I want to cry, like, and what a beautiful soul, like to find, to help you. And so, just finding your people. And I say that all the time. And I love how Gyno Queer has a private Facebook group. I love that Lauren from Endo Black has a private Facebook group. There are communities out there. There is a community for everyone. And finding that community is really life-saving. Not only can you find better doctors, tips on multidisciplinary care, but you find, like peace and hope in that you're not alone.
Definitely, definitely. Uh, if anybody has questions, you can ask too. I know I have my list of questions, but feel free to ask. Feel free to ask.
Yes, please. I saw a couple people coming off mute for a moment before. Please jump in.
I think I saw Stephanie was trying to come off mute. Stephanie, you had a question or a comment?
Good evening. I really more just have a comment. And just wanted to say hello and wanted to like show my face for 2 seconds because and I actually know Casey. I feel like we got to meet one time in New York at something. And I just want to celebrate the work that all of you have done. I follow you and or we follow each other. I am Miss Steph underscore TFE on Instagram. And so for those of you following me and celebrating and the working together, I am of Bayesian descent. And so all of those things helped me just kind of feel, Dr. Thomas, as you were sharing, just feel less ostracized. And one thing that I will also share that Casey brought up, the idea that like you're the only one of the things that I'm so thankful for, once I shared it with certain groups that I was in, come to find out so many, because statistically speaking, we cannot be the only one. But you don't know until you speak up or until you find the other one. Once you find the other one, then it's like 15 other people. You're like, oh, you're in a conversation. It's like, oh, almost everybody has it, which is why it's so tragic that we're just so, the treatment is just poor. So thank you all so much for having this evening. I just, like I said, I just wanted to show face and let you know, back to Casey's point of like, I am a real person. Not just here sitting, listening, or ogling. I'm participating, and I thank all of you for all the work that you do.
Stephanie is amazing. If you don't,
Yeah,
oh, good, you follow her too. Like,
yes, and I didn't know she was a bitch. Julia and I heard this comment. Hey.
she's single-handedly like inspiring the next generation of scientists by her amazing work. So I like love following Stephanie's account and just am in awe of like the work that she does.
Yes, me too. I did not know. Well, hi, Caribbean sister. Oh, see, if we don't say anything that we don't know. Now we know. Yeah, so Julia will be in touch. And so will I. Okay, I'm going through my list. Next question. For people living with endo who may be feeling overwhelmed, dismissed, or exhausted by the healthcare system, what message of hope would you want them to take away?
Honestly, this probably seems counterintuitive, but I think stressing that it's okay to grieve hope, that it's okay to uh, take time, like if you're feeling tired, overwhelmed, or sad, to just to grieve how hard it is and to process that. And then I think where I find hope is really in community, not to sort of be redundant from the last question, but I think there's hope in all of the incredible nonprofits and patient advocates who continue to, push the needle forward and fight for change. I think, and Heather could probably speak more to this. Because I feel like Heather's been on here. I think what was it, like the AOL chat rooms? Like I feel like I have heard you talk about that. Um, and I think there are things that are changing in positive ways. It feels so slow at times. Um, but I do think that there's change, and then also there's more folks to be able to just hold you like when you're feeling exhausted, and to not gaslight you. So I think there's hope in that um, there's more awareness now and more community.
Yeah, I'll agree with that. That's
Yes, Heather, please let the queen speak. What say you?
I don't want to take a single thing away from Miss Casey and everybody else who is talking. This is like the best event of the whole year.
Heather, is there hope? Where's there hope?
Is there hope? You know what? That's a really fair question. Um, yes, I mean, yes, of course, there's always hope, right? I mean, we spend so much time in the darkness, we forget. You know, a lot of folks are very topical, and that's fine. You know, their advocacy takes them where it does. For others of us, it's a full-time thing. And you know, it's hard for the helpers to ask for help, right? And Casey, I know you know this better than anybody. And at times it really looks like it's just doom and gloom and the inertia is real and we never progress and we never get anywhere. But then when we look back, it's like, oh my God, remember? Um, yeah, there is always hope, and I'm most encouraged by the incredible people that are in the trenches. You know, I look around to my left, I see Julia, I see Alicia, I see Casey, I see everybody from, SVG and Lotus and Shannon Cohn and oh my God, Jenna, and all of just the amazing people that we collab with. Um, it the hope is there, and it's because of all of you that bring it. So yeah, never lose hope. Never lose hope. That's all we've got. That and gallows humor.
Thank you so much, Heather.
I just
And
love all of you from the bottom of my heart. I could not do this without my village.
and I know I can speak for all of us, and we love you right back.
Swoon. This is like the best event of the year. I wish we could do this like once a night.
Right?
I know, right? We need to do this more often. So let's
Wonderful.
put that on our little board. Maybe we can do it every quarter or something, just us.
That would be so cool.
Yeah,
That would be cool.
yeah. We'll put
I
it on
think
a.
the helpers need an outlet too, right?
Yes, I agree with that. For sure. I agree with that. And I only have two more questions.
Okay.
And I think Heather could jump into this one too, as
All
well as
right.
Casey. So this one is for just some maybe encouragement or guidance for somebody who is recently diagnosed. What would you say to them?
Well, that's all you, Casey, Mama. Go ahead.
Um, y- you are in community with strong, resilient um, people who love you and got your back. That it is a challenging, difficult disease, but and also um, you still have so many strengths and gifts to share with the world. And while there are challenges, like it'll also be okay. It'll be okay because I think humans are really strong and they can adapt to really hard things. And there is hope.
Yeah, for sure. I believe that. If there was one thing, one change you wish every healthcare provider would make tomorrow morning at
Oof.
8 a.m. in how they care for us as endo warriors, what would that one thing be?
Oh goodness, that is a really good question. That is a really hard question. Um, it would be um to it would probably be to that endometriosis requires expert multidisciplinary care, and they best be referring patients to it. I don't know if that's two things, but I'm gonna count that as one thing.
I count it as one.
Okay, good.
Heather agrees.
Hmm.
I agree with that 100%. As of 8 a.m. in the morning, I wish every provider would do that. That would be like my dream come true.
Yes.
I don't have any more questions. Does anybody else have a question for Casey while we have her captive? Or a comment? No? All right. Casey,
Wait. I just want
oh
to
wait.
tell her again, the book is amazing. And thank you for the resource.
Oh my goodness, thank you for letting me include your incredibly important work in my book. That was like, I'm so grateful for that. And it was such an honor to be allowed to do that. So thank you.
No, oh, of course, of course. The honor is mine and ours. I'm speaking for the research team that you wanted to include it. So thank you. We're definitely gonna have to get some of those books in Barbados and yeah, but thank you. Thank you for your amazing work. And I see that you're gonna be so busy, but it's gonna be so good.
Yeah.
Thank you.
All right. Stick around for just a little bit longer. We have to do our raffle. Is there anyone on the guest actually in St. Vincent? If so, please like raise your hand, say aye. Otherwise we'll do one spin of the wheel. Yep. Okay. So let me share my screen. And while I'm working on that, Kimet, can you give everyone a preview of what we have to come for the rest of the month?
Hi, good night, everyone. Sorry, I joined in a bit late, but I could tell the energy when I came in was just truly captivating. A lot of gems came out, Odelia saying the same system that traumatizes us is the system that treats us. So that stuck with me. And also Heather saying, never lose hope. That's something I think we should all take away from tonight's session, right? It might be hard, but never lose hope. Keep pushing, keep working towards everything, and better will come, right? So as Alyssa said, we have a few more events coming up, virtual events, just to let you know what they are on the, one second. So on the 17th, which is Tuesday, the 17th of March, we have a session with Dr. Eugenio Colon. And so we're going to talk about the bizarre and the peculiar and the strange when it comes to endo. So that's looking to be a really interesting session. And we hope that you could tune in. Stay tuned to our pages as we'll share more in the flyer. That's supposed to happen at 7 o'clock. And so we hope to see you there. There's also a session called Why Endocare Fails Black Women, and that's with Dr. Small Lane. That's happening on Thursday, the 19th, also at 7 p.m. So we look forward to seeing all of the registrations coming and to see persons in attendance at those two sessions.
All right, fantastic. And here goes the wheel. Okay, Ethan is our winner. Ethan, please, can you send me your email address privately, and then we will make sure to get get your book out to you. Thank you all, everyone, for joining us. Thank you, Casey. That was really, really amazing, not just for going over the new guidelines, but telling us how we got there and the blood, sweat, and tears that have got us to this point. We really, really, really appreciate you. And thank you again to all of our guests who came out. We appreciate you for coming out, and we hope to see you all at our future speakers events. And thank you again. Thank you again. Thank you, everyone. See you soon.
Thank
Bye-bye.
you. Bye.
Thanks, everyone. Bye. Good night.
Bye.
Good night, everybody.
Good night.